us. I'm Corinne Highland, Information Officer for Santa Cruz County Public Health. I'll be moderating today's Clinicians Resource Call. The purpose of this meeting is to support Santa Cruz County clinicians in the evaluation and clinical management of patients and provide updates on public health trends. Public Health hosts this call monthly on the second Tuesday morning from 7:30 to 8:15 a.m. As we go through today's call, please submit your questions via the Q&A function rather than the chat, and we'll do our best to address all your questions. We'll also send out the slides and resources to all attendees in the next day or so. Today, we'll start with a welcome from Pam Connolly, our Deputy Director of Public Health, and then we'll move on to a presentation about perinatal mental health, followed by our public health update. So now I'll go ahead and hand it over to Pam.
Good morning, everyone. Wonderful to be here with you. I'm going to keep my comments really brief. We've got some incredible content to share with you today. I want to thank everybody who filled out our survey over the past month. And we want to add it here as well to give you another opportunity. We want to make sure that the content we're providing is relevant and timely and something that is worth your time here early in the morning to attend these calls. And so we'd like to ask again for your feedback just so that we can make sure that we're being responsive. So I know we've got the QR code here. I think Corinne may be able to put the link in the chat function as well. And we can go to the next slide. We are sharing this resource. It's been making its rounds around the community. It's a partnership between UC Berkeley and UC Santa Cruz about the ability to organize and respond to ICE when they are in our communities. And this next one on the February 25th is geared towards clinics and hospitals. So we thought this was a good venue to share this with you. And we'll just take a minute to I'll pause here for a moment just to see if you want to grab that QR code now. Otherwise, it will be in the materials when we send those out in the next couple of days. And this is a public resource, so feel free to pass it on to your colleagues. And with that, I will pass it to Dr. Cal Gordon to kick us off with our content for today.
Hi, everyone. Dr. Cal Gordon, we can move to this slide. I am the Maternal, Child, and Adolescent Health Medical Director for the county. And we have the good fortune of having Drs. Nirmaljit Dami, who's the Medical Director of the Inpatient Perinatal Psychiatry Unit for El Camino Health, as well as Charlotte Alexander, who is a Salud Palagente OBGYN physician, as well as OBGYN hospitalist at Watsonville Community Hospital. And we're using a case-based panel discussion to address the important issue of perinatal mental health for frontline clinicians. We can move to the next slide. So the purpose for today was really to review the perinatal mental health disorders across pregnancy and postpartum, to differentiate the different types of perinatal mental health disorders, to initiate evidence-based screenings and first-line management, to recognize indications for urgent psychiatric consultation or inpatient care, as well as to really outline what's available for us locally as well as out of our county for perinatal mental health resources. We can move to the next slide. So we'll be going briefly to talk a little bit about sort of the epidemiology of mental health disorders, as well as what is offered at El Camino Health, which is a great resource for our broader community. And we have representing El Camino Health, Dr. Nirmaljit Dami, and then we have Charlotte Alexander representing as the frontline OB hospital-based physicians and providers to have 3 cases that we're going to review. In the interest of time, we may not be able to fully review the 3rd case, but we will at least address the important aspects of management. And so that will be what we'll be how our format will be. And then finally, we'll be addressing key takeaways and resources. So we can move to the next slide. And this I'll hand over to Dr. Dami to give us some general background on the perinatal mental health disorders.
Great, thank you. Can everyone hear me?
Yes.
Good morning, and thank you for your introduction, Dr. Gordon, and very happy to be here. Um, so when we talk about perinatal mental health conditions, we're essentially talking about mental health conditions that affect women who are pregnant or up to 2 years postpartum. So that's the window that we're looking at. And why this is really important is because that is the time when women come in contact with the healthcare system multiple times. It's also a time frame in which they are very susceptible to develop these conditions. And if we look at prevalence, depending on where you are in the United States or worldwide, we're looking roughly around 1 in 5 or a little bit more. So these mental health conditions, and we call them PMADs, perinatal mood and anxiety disorders, are noted to be the number one complication of pregnancy and postpartum, the number one complication. So just as we screen for diabetes and hypertension and medical conditions in our pregnant women or a postnatal women, we have to keep in mind the mental health conditions that could be presenting. So this is an important opportunity, an important time in a woman's life, and an important opportunity for the healthcare system in general, and us as doctors and providers to assess, screen, and intervene. Um, we know that depression and anxiety are leading causes of morbidity and mortality. The World Health Organization has that data, but maternal mental health conditions contribute significantly to maternal morbidity and mortality. They affect functioning of the mother and thereby affect the functioning and the health of the entire family unit. That is why our ability to assess, screen, and refer and treat matters a lot. We're not just treating one person, we are really focusing on the well-being of the entire family unit. Early identification and treatment is possible and will significantly improve outcomes. We've seen that anecdotally in our work here at El Camino, and that's pretty much led us to create the depth of the programs that we have, and I'm happy to talk more about it. It's not very hard to screen, and we'll talk more about that too. And then we know that we have a mental health crisis in our country and also in the world in terms of the number of trained psychiatrists and other providers that are available. In this case, though, I think our reach can be far broader because our obstetric colleagues, primary care physicians, and pediatricians can play a huge role in screening these patients quite effectively. With that, we'll move to the next slide. So, just briefly about mental health services at El Camino Health. El Camino is a community hospital. We're in Mountain View, California, not too far from our sister counties of Santa Cruz and Monterey. But we are one of our gems is our psychiatry services, and in that psychiatric unit, we have a 36-bed psychiatry unit, but in that unit, we have 6 to 9 beds that are dedicated to women and specialized for inpatient perinatal psychiatry. So if a woman is pregnant or up to 2 years postpartum, struggling with severe mental health conditions, meets criteria for inpatient admission, then we have the expertise and the ability to take care of them and help them in the recovery process. And our unit was the second unit in the country when we first launched. We actually opened right in the midst of COVID in August of 2020. But the process for getting this unit began many, many years ago, as it happens for all of us. So in 2008, April, we started what's called the MOMS program, or the Maternal Outreach Mood Services program. That initially was an intensive outpatient program and now offers partial hospitalization, which is day treatment, as well as intensive outpatient level of services to anywhere between 18 to 20 moms. And if a mother is struggling with symptoms that are significantly severe, then we have our inpatient psychiatry unit with a dedicated multidisciplinary team. In addition to that, here at El Camino, I believe we have approximately 6,000 plus births, and every person who births here at El Camino is screened for depression, anxiety, bipolar disorder, and safety using the standardized Edinburgh postnatal depression scale. And if the screen is positive, anywhere above 10 or a positive on question 10, then the patient is referred to for a formal psychiatric evaluation by myself or one of my colleagues. And we are then able to assess and determine what level of care is appropriate for them. In addition, we offer specialized services in our neonatal intensive care unit. So what I want to highlight is that our perinatal mental health services are not just located within the psychiatry department at El Camino. We work very closely with our OB team, our NICU team, and our emergency room team to screen and assess patients in real time and refer them appropriately. Through a community grant, as of 2008, El Camino also offers what's called Access, which is free screening for anyone that's referred from the community. So if you have a patient that that you think meets criteria for a referral to one of our programs, you can refer them. So all in all, nutshell, bottom line, we offer probably the biggest depth and range of perinatal psychiatric services anywhere in the country, ranging from intensive outpatient to day treatment, partial hospitalization, to inpatient services, and then screening and access through in the community as well as NICU and in our emergency room. Um, and we would love to have more referrals from our local area. Thank you, Dr. Gordon. Ready to move to the next one.
Great, thanks, Dr. Dami. So I'd like to have Dr. Alexander do the case presentations. And I should note, based on her experience as a practicing hospitalist, OB/GYN doctor, came up with these three scenarios that are, I think, representative of what may come through the labor and delivery presentation. So we can move to the next slide, please.
Good
Okay.
morning. Thank you for your introduction. Happy to be here. This is our first case scenario, and I think it's the most common that you are likely to come across. So this patient is a 38-year-old G4P4, and you're seeing her for her 5-week postpartum appointment, a routine visit, and IUD placement. Because it's a postpartum appointment, she's been routinely given a PHQ-9, and she scored 18 on that. When you chat with her, she says that yes, she is feeling some feelings of hopelessness, anxiety. She's not sleeping well, she's not eating well, and she doesn't feel like she's bonding with the baby, certainly not like she has in her previous 3 postpartum periods. She says she has no suicidal ideation, no homicidal ideation, but she's definitely not feeling like herself.
Thank you, Dr. Alexander. We'll move to the next slide, please. So for our discussion questions, what's the differential diagnosis? Would you recommend additional screening? And can you address first-line treatment options, considerations before starting SSRIs, and recommend follow-up timing? So
Great.
Go ahead, please.
Great, thank you. I can start with the differential diagnosis. So one way to think about this from a mental health lens is that this patient, I'll call her patient, has had prior pregnancies and prior children. So something to think about that will guide us towards a key differential diagnosis would be any prior history of depression, anxiety, or bipolar illness. And those would be, again, the top ones that I would think about. I would explore the anxiety more. Sometimes I ask patients on a scale of 1 to 10, 10 being the worst, how high is your anxiety? Specifically delineate what symptoms of anxiety they have, as in, do they ruminate a lot? Do they worry a lot? Do they worry about specific things? I would discuss insomnia and try to figure out, is it initial, is it middle, is it towards the end? What wakes her up? Does she wake up with racing thoughts? Would explore appetite. Is it nausea that's contributing to poor appetite, or are there other factors, or are there social determinants of health? I would talk about bonding, hopelessness. I would definitely explore the suicidal ideations more, even if a patient says no, and we can talk more about that in our third case. So in the broader differential diagnosis category, would think about depression and anxiety, pure anxiety disorders, and a rule out on bipolar affective disorder.
Great. Thank you, Dr. Domini. We'll move to case number 2. Oh, I'm sorry, teaching points. We'll move to the teaching points briefly.
Yes,
Go ahead.
Sorry, Dr. Gordon, may I go ahead, or?
Please, yes.
Okay, so I'm going to just mingle the discussion question and the teaching points a little bit. Try to keep this really brief. But PHQ-9 and EPDS are the commonly recommended screening tools. EPDS is very easy to administer. It comes in multiple languages and really separates out some of the questions of depression, anxiety, as well as social withdrawal. This is the tool we use. Our cutoff at El Camino is 10, which is a little bit lower, but the reason why we keep it lower is because we know that patients underreport their symptoms, especially in pregnancy and postpartum. So screening can be done very easily using these two tools. Here at El Camino, we use a couple of other screening measures too. Sometimes people use GAD. It is very important to screen to the best of your ability for bipolar disorder. And the reason being, a bipolar disorder manifests in the postpartum period much more. So having your really thinking about how to separate out a mood disorder is important. Some key questions would be, is there a family history of bipolar affective disorder? Has the patient ever experienced bipolar symptoms? And the symptoms may not just be mania, it could be agitation and irritability. One other clue would be to educate the patient that if they're starting an antidepressant, they need to monitor themselves for increased level of agitation. That would be those are my thoughts about screening. It's also important, really important, to counsel the patients that antidepressants need to be titrated up, but the titration has to be slowly done. Psychotherapy is an amazing, amazing add-on, teaching patients about how to manage their mood, how to understand the change in their life, the change in their family unit, the change in their responsibilities, and put that in the bigger context of their life as it used to be before is important. Psychotherapy with both the patient and their support system, their partners, their spouses is also important, as we know that these conditions don't just affect the patient, but also the family. And there's always a balance of using psychotherapy along with medications, and that's been shown to have the best outcomes especially for moderate and severe mental illness. It is very important to have close follow-up with the patients, and I think the key here is for the patient to trust the doctor, the provider, and have the faith and the trust to come back to you if their symptoms get worse. So one of the things I always tell patients is it's not their fault. Symptoms wax and wane. They can always call and come back, and we're here to help. And it's not their fault again.
Thank you, Dr. Dummy. We'll move to case 2.
So in this case, you're seeing a 24-year-old G1 at 7 weeks gestation for her first prenatal care appointment. She has a history of schizoaffective disorder that has been well controlled on quetiapine and olanzapine, but upon learning that she was pregnant, she stopped all of her meds. This is a common scenario for any kind of chronic health condition where somebody is taking their medications. They find out they're pregnant, they think they shouldn't be taking any medications in pregnancy, and so they stop. This has the potential for becoming a psychiatric emergency if somebody who was previously stable on their psychiatric medications stops their psychiatric medications.
Great. Thank you, Dr. Alexander. We'll move to the next slide. So our questions are, can these medications be continued in pregnancy? What are the risks of untreated illnesses? Should OB or the primary care provider refill the medications? What are the breastfeeding considerations? What dose adjustments would be needed? And are there available county resources around some of these questions?
Um, so, I can start to field some of these. Um, yes, these medications can be continued in pregnancy. I often will consult in front of the patient, either, Dr. Hale's infant risk, LactMed, and show them the discussion of the risks and benefits of continuing these medications in pregnancy for the specific medication. Um, ACOG says that it's important to weigh the medication risk on the fetus with the risk of untreated mental illness. And I tell my patients, you need to take care of yourself in this pregnancy. And if you're not taking care of your mental health and not taking care of yourself, then you can't take care of the baby that you're growing.
Great, thank you. And Dr. Dami?
Yes, so first of all, these are great questions. Thank you for answering. And my take on this is no. First of all, do not stop your psychiatric meds. If you are stable on your medications and you find out you're pregnant, call your doctor right away, but don't stop your medications. And in terms of risk, I think one way of thinking about it is the risk of untreated illness and the risk of medications. So what we do here in perinatal psychiatry is risk decision making that involves the patient, their family, and we discuss this openly, but stopping medications poses a greater risk, not just to the baby, but also to the patient. And should the OBs and the PCPs refill medications? Yes, I think our duty is to help our patients to the best of our ability. And there are many consult lines that are available where you can reach out to a provider who can give you information. Breastfeeding considerations are very important and an important part of the discussion that needs to be started early on. So when the patient discovers they are pregnant, I think starting that discussion is very important and we can help. There are many ways in which you can breastfeed, even on a medication like lithium. Dose adjustments are always needed because somewhere around 24 weeks or so, the blood volume becomes very dilute or increases significantly, and that requires a dose adjustment for most medications. But that being said, anecdotally, it's much easier to manage psychiatric symptoms in pregnancy than postnatal. And we really want to get a head start on managing things in pregnancy. So the postpartum period is much easier.
And it's not uncommon that a primary care provider for mental health is not comfortable treating pregnant patients. So I often find that I will need to refill this patient's medications while we bridge them to somebody like Dr. Dami, who is comfortable managing these patients in pregnancy.
Thank you.
Yes. Um, Yes, and we'll make a point in this emergency piece. So yes.
Great. And in terms of available county resources, we actually have in the appendix our resources, and if we have time, we will go over that. But I also, Dr. Dami, if people were having questions, does El Camino Health also offer that opportunity if people feel like they're not quite sure how to manage their cases?
Yes, we have. I'm available usually by email, not as available by phone because of my inpatient responsibilities, but I'm happy to help. If someone has a curbside question, happy to help. And maybe after this call, Lauren and I can sit down and put together some resources that are for providers. But yes, I'm
Right.
happy to support where I can.
Great, thank you. And there are other options, I believe, that we have listed in our resource slides. So we'll
Mhm.
move on to our takeaway or key takeaways.
Um, I can take a dig at it and then pass it on. Um, so very important to think about the mother, the patient here. Mother's mental health is critical and central to her well-being and the well-being of the baby and the well-being of the family. And that's, I think, my North Star or my guiding principle here. And mental illness, in moderate mental illness, warrants continuation of medications. When we stop medications, what a lot of patients don't understand is it's not just, oh, I stopped taking a pill. Our medications work through a very complex process in the brain, and they are shifting they're rebalancing the neurotransmitters, and suddenly stopping the medication is like a shock to the brain. You can have significant withdrawal symptoms and worsening of symptoms. And in that process, symptoms can get worse. And then to restabilize may take more medications, more time and effort, and sometimes inpatient hospitalization. There is also the risk of um, psychiatric emergencies like suicide or worsening intrusive thoughts and infanticide that comes with untreated or poorly treated mental health conditions. Um, Collaborative care is the best. Patients have the most contact with their OB team and subsequently with their baby's pediatrician more than with us psychiatrists. So, collaborative approach where we're giving the same information to the patient, prioritizing their mental health care along with their physical care and OB care is very important. And many medications are compatible with breastfeeding. The two key points here are lithium and clozapine. It's very difficult to manage the baby's health when a woman is prescribed these two medications. So I often say, we avoid breastfeeding with these two, but more recently I've been able to work with some pediatricians who have been supportive and have been helpful in checking lithium levels in the baby. So in general, most medications are compatible with breastfeeding. And if you can work as a team together to optimize and prioritize a women's mental health, then they can breastfeed safely on these meds.
Great, thank you so much. So we will actually skip the case presentation for case 3. It is based on postpartum psychosis, and we'll move to actually the teaching points of that case. So we could skip forward. You can review the presentation and the questions. And so perhaps Dr. Dama, you can start about the teaching points around postpartum psychosis.
Yes, absolutely, Dr. Gordon. And thank you so much for this. This is like one of my passions, and I'll tell you why. Number one is postpartum psychosis is essentially a psychotic condition that can happen in the postnatal period, but we also see it in pregnancy. Psychosis can present with depression, can present as a spectrum of bipolar illness, or can present as psychosis itself. When we say psychosis, it means it's a break from reality. Postpartum psychosis is a psychiatric emergency, and the literature says it's anywhere between 0.07% prevalence to 0.01%. Clinically and anecdotally, we know that it is more common because it presents in many nuanced ways. The key principle, the one golden nugget here is symptoms of confusion and disorganized thinking. If you have a postpartum patient who comes in saying, I'm really confused, or the family says, this person is really confused. I don't know what's happening with her. She's not able to do things the way she was doing before. It's really, really important to explore that. What do they mean by confusion? What do they mean by disorganized thinking? Very simple way to remember this is the mind can go from point A to point B to point C. For example, if I want to make a peanut butter sandwich for myself, I know what to do. I'll get two bread slices, I'll toast them, I'll put the peanut butter, I'll put the jelly, and the sandwich is ready. When a person is having postpartum psychosis, they cannot do these simple steps. So they will have difficulty changing a diaper, they'll have difficulty preparing formula. And that's the earliest sign. So very important to know, it's called psychosis, but presents in what we call a delirium-like picture with confusion and disorganized thinking. The second really important thing is that these symptoms can wax and wane. So a patient may look perfectly okay to you in your clinic, but go home and be very, very confused. And if the family comes back and says, yeah, she was okay in your clinic, but not at home, that is another clue that you may be looking at a psychiatric emergency. And why is it an emergency? It's an emergency because women have thoughts that they have difficulty managing, they're confused, and this comes with a 4% risk of suicide and a 5% risk of infanticide. And oftentimes in our country and around the world, we know of cases, we find out from the media something has happened, but if you dig deeper, you will find a prodrome and a build up to it. So please learn more about it. The very, very, very important thing, and I want to underscore this, is this is a treatable condition. Early intervention, treatment with the right medications is very, very helpful, can be life-saving. And this is a condition in which a multidisciplinary team and a system like El Camino comes in, because this is when you need a psychiatrist, a social worker, nursing staff, along with family interventions, and all of these people and teams come together with the goal of treating this condition and helping save the patient's life. So key points: confusion and disorientation, disorganized thinking, treatable condition, and high risk of suicide and infanticide. And the gold standard for treatment are medications like lithium along with antipsychotic meds in a multidisciplinary safe setting like an inpatient unit like ours.
Great. Thank you so much, Dr. Dami. We can move to the next slide, please. So when to refer to escalate, I think, Dr. Dami, you touched on this. Do you have additional recommendations in terms of wanting to kind of escalate or to refer to a higher level of specialty? Does this is in alignment with your approach?
Yes, absolutely. Thank you, Dr. Gordon. So again, I tell our staff this all the time. In fact, had this conversation last night with our ER team. But when in doubt, just refer, because these conditions are nuanced. A patient cannot come to you and tell you, I have homicidal thoughts. A patient will say, so usually suicidal ideations in pregnancy and postnatal period present in nuanced ways. Patients don't come and say, I want to kill myself right now. What they will say is, I don't want to live. I wish to disappear. This is not the life I wanted. What do I do? Or I've thought of leaving the house. I've packed my car. I've almost sat in my car. And these are some real life clinical scenarios I'm describing. So that is when you think about, what do you mean when you say your life is not worth living? Tell me more. They may be able to tell you more or they may not. Either way, refer or escalate. And loop in their support system. But remember, the support system may not be able to give you information too. So when in doubt, always refer or escalate. we talked about suicidal thoughts. There are also infanticidal thoughts. Sometimes mothers will start by saying, "I wish I'd never given birth." And eh, we had the situation last night, actually, and I had the nurse go back and explore that more. What does that mean? Sometimes women have intrusive thoughts of harm coming to baby or themselves. These are very common. 40 to 60% women that have postnatal depression and anxiety have these, 40 to 60%. These are images of either harming themselves or their babies. These are ego dystonic. They are very uncomfortable to women, but women have them. So if you have intrusive thoughts, explore that with the patient and refer. Give them the resources. If a person is disorganized, looks disheveled, poor groom, is not eating, that indicates a significant withdrawal from themselves. That is also a big red flag. But my key point here is when in doubt, refer or escalate. If remember, suicidality can be nuanced. Remember, patients can't tell you this because they don't know, but they'll give you clues about withdrawing from their life or leaving their life. And then if medications are not working, they're getting worse, they're still not able to sleep, getting agitated, important to refer. So in all these situations, just call.
Thank you, Dr. Dami. We'll move to the next slide, and I think this summarizes the points that we've addressed. So we will this will be in our package, and people can look at that. We'll move to the next slide, please. We also want to let you know about our various resources. This kind of lists out what are some of the ones there. I want to show the next slide, which highlights what's available at El Camino. There is a direct line option where you can, if you feel like admission is warranted, this is one way of accessing El Camino Health. And we have a link to more of their resources on this, which will be part of the slide deck that will be sent out. And then we have a series we can go through quickly for people to see a series of slides that are specific. There's another contact number for potential management for that's available to providers. It's a free service. And we also have, next slide, what some of the things that are available in the county proper. So you can speak to the mental health coalition. If people would like to join as providers, they are welcome to this effort. Next slide. And then we have our children and family health home visiting programs that if you feel people are at risk that are for consideration, this is a resource available for you. We do have one question I think that was presented about whether we have LGBTQ services are available at El Camino Health. We will answer that in the Q&A, and we will be sending that answer out in our communication to you. So I'll hand this now over to Corinne Hyland, who I think wants to address a couple key points. We can keep going.
Thank you for what an informative presentation. I do want to point out that in the Q&A that it was, like Dr. Gordon said, asked if El Camino is open to transgender, non-binary patients, and the answer is yes, that they do individualized care plans. So that is in the Q&A for all to see.
And Corinne, if I could just thank again Doctors Alexander and Adame for their wonderful participation. This was a real a benefit for our county. So thank you.
Yes.
Thank you.
Yes, thank you so much. I'm going to very quickly take the next slides. Again, this is Corinne, and I'm the Public Information Officer for the county, but I also have the role of overseeing our Healthy Communities branch, which oversees our local oral health program. Next slide, please. And so February is National Children's Dental Health Month. And so we have just a couple reminders for our clinicians. Next slide. The first is reminding parents to take their children to the dentist by their first tooth or first birthday. And we have a few resources here that will go out, including a flyer on what to give families that might need a dental home. The second is reminding parents to fill out their kindergarten oral health assessment forms. This usually goes out with the kindergarten enrollment packet. Third, we are seeing quite a drop off in teen dental visits after age 9. So encouraging families to take their teens to the dentist is another thing that we could do as we see teens in the provider office. And lastly, apply fluoride varnish in the well child check. And this slide also has resources on how to get reimbursed for this service in the provider's office. So, real quickly, wanted to go through that as we run out of time here. So, again, all these resources will be sent out in the next day or so. So, I will now hand it over to Dr. Leclerc Cortez for our respiratory virus.
Thanks, Corinne. Next slide. So I wanted to give a summary of the respiratory virus trends for the month of January. Thankfully, COVID continues to be somewhat low. The modeling is showing the reproductive number around 0.8 to 0.9, so still low, but slightly increasing from the prior month. This is based on hospitalizations, which continue to be low, and the wastewater concentrations, which have also thankfully been low for COVID. The one that we're keeping an eye on is influenza. We've seen in the wastewater that in the month of January, there was quite an increase in influenza A. It's at a moderate level at this point. Talking anecdotally to the hospitals, it seems like in the past couple of weeks, they've seen quite a burden of folks presenting with flu A. And of course, following events like the Super Bowl with a number of people gathering for that, we always anticipate that there will be a spike in respiratory viruses in the following weeks. RSV thankfully continues to be slightly increasing, but still pretty low. And you can go to the next slide. This is just a visual of that COVID transmission, which you can see is thankfully the reproductive number is continuing to be below 1 for the past couple of months. So that's all I have. I'll pass it back to Corinne.
We're right back on schedule. Thank you. Is there any questions that anyone might have about some of the information that they heard today? Well, hearing none. Again, the slides will be sent out, and a video of this call will also be sent out in the next couple days. I want to thank everybody for joining us, and just another reminder to please fill out the feedback survey. That is, the link is in the chat as well as on the slides that will be going out. So thank you again for your participation, and I hope everyone has a great week.
Thank you.